Welcome to In a Heartbeat, coming to you today from the studios of WMTV Channel 5 at the War Memorial in Grosse Pointe Farms. I'm Dr. David Balle, and I'm your host for In a Heartbeat. Today, we're having a discussion on a very important topic that, whether we realize it or not, affects all of us in our lives. And we're going to be talking today about the opioid epidemic or opioid crisis. And I'm very pleased and honored to have as my special guest, as an expert to talk about this, who's very knowledgeable, Judith Malinowski.
Good morning.
Judy, thank you for coming to In a Heartbeat and for taking time out of your day to be a part of us and to share with us the information that you have.
Thank you so much for inviting me. I appreciate it.
So Judy, what I'd like to do to start out, why don't you tell us a little bit about yourself and your background?
Okay. I've been a clinical psychologist for over 30 years, which always is quite surprising to me when I realize how long I've been in the field. I started out in the field of chemical dependency as well as mental health. And for the past 5 years, I've worked for Eastwood, which is part of St. John's Providence, our Ascension Health, here in the Detroit metropolitan area. We have 12 outpatient clinics that treat not only substance abuse, chemical dependency as well, but also mental health. We also have a residential care unit for indigent clients, so those clients that don't have financial support, don't have insurance, that are able to go to a residential facility for detox, for treatment for their substance abuse. So Eastwood has been in existence for over 30 years. So it has a long, long history. It started here on the east side and has grown. I'm at the farthest west location, which is in Novi, but we have locations in St. Clair Shores and right here in Moross, right on Moross and Mac, as well as Shelby Township, you name it, we're all over.
Great, great. It's a needed entity. So for viewers who may not know, can you help us by saying and defining what is an opiate?
It's a good question because many people have a misconception about what an opiate is. And if we were to get into the basic definition, it is any substance that's derived from the opium poppy. So we start out with opium and morphine, but then we move to the synthetics. And those are probably the major concern that we have right now. Whether we look at Vicodin, Oxycontin, oxycodone, fentanyl, Tylenol 3, any of the products that not only are they an analgesic, so they are a pain blocker, but they're also a euphoric. And as we say, you not only don't feel the pain, you don't care. So there's a euphoria aspect of it, which is truly what's creating this crisis.
So there is an opioid epidemic or crisis going on. Do you have any insight that you could share with us from your point of view and your perspective? How did this happen? How did this evolve?
That is an excellent question. I was looking at some of the research, and it started to explode about 16 years ago, where the use of opiates quadrupled. Part of it was, I believe, when a person goes to see their physician, the physician is duty bound to first create no harm or do no harm, but also to help alleviate pain, to help the patient feel better. I think before people realized it, these opiates were being prescribed significantly by many doctors that may not have understood the long-term consequences. And then the strength and the potency of the medications increased significantly. So here we went from perhaps a doctor prescribing a Tylenol 3, which has Tylenol plus codeine, to prescribing a Vicodin or prescribing, an oxycodone. And then what started to happen was people tend to not throw out their medications. And this is what is the biggest issue, is called diversion. So I go to the dentist. Perhaps I'm getting wisdom teeth or having some sort of dental work, and the dentist prescribes Vicodin. 9 times out of 10, they're going to prescribe a 30-day supply. That is just the standard prescription. However, I don't take 30 days worth of Vicodin. On the average, most people take 3 days worth of medication for pain. Where does that medication then go? It goes into their medicine cabinet. It goes into their cabinet in their kitchen. People don't throw away medications because they paid for them and they think, well, you know, there might come a time when I might need them again.
Sure.
What started to happen was individuals who had become physically dependent, and when we talk about physical dependence, it means that when a person stops taking the medication, withdrawal symptoms start to happen. So that's the clinical definition. I am physically dependent, that when I stop, I start to go through withdrawal. Withdrawal is very unpleasant. People want to avoid pain. So then they start looking for alternatives. And then what's really hit the medical field was about 2 years ago, they reclassified the drug. And now all opiates are considered to be a Schedule II. And I won't bore you with all of those details. However, what it means is you can no longer get refills where you in the past could. So where if I went to a doctor and perhaps I was seeing the doctor for back pain, or I was seeing the doctor for some long-term chronic illness or chronic pain, and the doctor was able to give me 3 refills of 90 pills, I can no longer receive that type of prescription from a physician any longer. I can only receive a prescription for 1 month at a time. This created a great deal of problems with individuals because then doctors were being scrutinized as to how much and how often they were prescribing these highly addictive, highly abusable medications. So the FDA came down and they said, we have to really put the kibosh on this, so to speak. Well, then many doctors, many primary care physicians or doctors that may necessarily not have had any kind of background in pain management were being scrutinized, and they were realizing this is putting me at risk, and I'm not going to put my medical license at risk. I need to start addressing these issues with my patients. That's where often doctors would then refer that patient to a pain clinic. Now we have another doctor coming into the mix. He's going to look at the situation and say, well, there are alternatives to this. But now we have a patient who's physically dependent and emotionally dependent on a medication that they may not be able to get.
Or, I'm just listening to what you're saying. Maybe they're under a subconscious perception that, I belong in a pain clinic, and, is there any end to that? Is there any end to that?
Exactly. And oftentimes what desperate people will do is desperate measures. They'll start what we call doctor shopping. They'll go from one physician to another physician to another physician. And even though I have high regard for the medical profession, as in any profession, there are those persons that are unethical and immoral, and they're in it for other reasons rather than helping people with their pain or their suffering. And it started to become a significant cash driver. Mm-hmm. So then we started having, there's stories and incredible documentation on, say, down in Florida, where we have actual clinics where people are going in, they're not in any type of physical pain, but there's a physician there, he's writing the prescription.
Or somebody may share this information with somebody in a casual conversation and end up at a pain clinic without a referral or a specific reason. Listening to what you have to say, I had a question. I was curious as to your thought. As a physician myself, not infrequently, as I evaluate a patient, I may think a certain drug or medication is the best option for the patient. But ultimately, that all is under the scrutiny and approval of the insurance company. So whether I think something is the best or not, probably, although I don't like to know that, it's the reality, has no relevance perhaps to what the patient may actually get. So a patient's prescription plan may say, I'm going to only cover this, but I won't cover this, what I want them to have. And so the choices sometimes that are available to the patient aren't really what the doctor prescribed. Do you feel that in any way has an effect on this?
Oh, I think how many years ago, and you probably remember when managed care came into being, and it stopped being the clinician developing a treatment plan and those types of what you were just talking about, to the insurance company saying, this is what you're going to do, this is how long you're going to do it, and these are the end results that we want to see.
I think sometimes people don't
realize that. They don't realize that unless they're in a situation where they're either in the profession or there's someone looking for services. And they're said, they're told by the treating physician or the clinician, this is all I can see you, this is all I can do. And there creates this state of confusion of like, well, who's in charge here?
And I think there have also been some recent reports, which are a little bit disturbing to me, about sometimes, maybe even in Congress, lobbyists wanted certain drugs to be more readily available, and some, I think, laws were passed to facilitate the easy access to opiates through the back door.
Well, it's interesting that you mentioned that. A couple of months ago, I was watching 60 Minutes, and they were talking about two of the largest drug distribution companies, McKesson and Cardinal, and how these companies were literally flooding the market with opiates. And so when you look at that and you understand what is the point, what is their purpose, which is, it's greed. I'm going to just...
To sell more.
It's to sell more, because if I can get someone addicted and physically dependent on something, then I'm making more money. And what happened
and it's
then,
endless.
the well started to dry, the river started to dry up, and individuals who were physically dependent then started to go to the street. When somebody goes to the street, what I would pay or what you would pay with a normal medication plan, a prescription plan, now you're going to pay $30 to $40 for one pill. That becomes pretty cost prohibitive. And so then we have the transition to something cheaper, but just as highly addictive, and that's heroin.
I'm going to ask you a question that may be obvious, but I'd appreciate your point of view and your thoughts. Do you have any statistics on this crisis that you feel important to share with us? And is this happening around us where we live in our community, or is it only on the news somewhere else miles away?
I think it's important to understand that in the last 16 years, and I know that that seems like a great deal of time, but the use of opiates has quadrupled, which is mind-boggling when you think about it. So the average person who may not have ever had any experience knowing someone who was addicted to these medications now knows someone, and it reaches every demographic. It doesn't matter where you live, what your socioeconomic status is, your culture, it is everywhere. What I think is what really is creating the crisis is that we have a demographic now, the 15 to 25 to the 30-year-old, upper middle class, individual who is now abusing these substances. So now we have teenagers, we have young adults, individuals that are not taking these medications for pain, at least not physical pain. They are taking these medications because they are looking to medicate themselves emotionally and psychologically. And this is where my passion comes in. When I look at what's going on with our young people and how many young people are dying because they have started taking grandma or grandpa or mom and dad's leftover medication that's been in the medicine cabinet, stolen it from their friends, done different things like that, and now they're taking, because they can't get it anymore, now they're going to the streets, purchasing heroin, which may or not be laced with fentanyl. We've created a whole new difficult, a whole new issue.
To your point, Judy, if a parent or a grandparent or a loved one were listening to what you said, and as a precautionary measure, what would you advise them to do to protect their household?
First off, what's really wonderful, and this is a new thing, physicians are not prescribing like they used to. So if you go to a doctor and you have, say, a sprained ankle or whatever the case may be, 9 times out of 10, they're only going to prescribe you 2 or 3 days worth of medication, which I think is phenomenal. So we're nipping it right there. We're limiting the supply, which is always important. But if anyone has any leftover medication in their home, there are many places that they can take that leftover medication, whether it's to the police department. There's always, periodically they have, medication take-backs.
And Judy, you bring a great point. We shouldn't just throw it away or flush it down the toilet, because that gets into all our food and water supply.
Not a good idea.
There are designated areas and means by which we should discard and dispose of old medication. And so if nothing else, you can take it to your local police department.
Absolutely. No questions asked. They'll take it and they'll dispose of it in a safe way so that it doesn't go into our water supply. They're not going to, do not flush it down the toilet, so to speak. That's what the most important thing.
So I'd like to ask you, as an expert, what are some of the signs and symptoms of abuse that we should all learn to recognize?
They're fairly clear-cut when you start to look at it. However, when we're looking at, like I said earlier, about that demographic that might be in their teens or early adolescence or even late adolescence, that tendency to withdraw from the parents and be more connected to their peer group, that tendency to maybe be short-tempered, perhaps a little oppositional to their parents. But you can notice it if they're tending to sleep a great deal, because that's one of the side effects of opiates, is that we tend to sleep. That's called nodding out, so to speak, just randomly nodding out. Constricted pupils, lack of appetite. Who are they associating with? Where are they going? What are they doing? Those are the types of things that I think parents, and this is in Parenting 101, know who your children are hanging out with and where they're going and what they're doing. And oftentimes when we're dealing with teenagers, the last thing they want to do is tell you where they're going and what they're doing. But it's, as far as being a parent, you're not their friend, you're their parent. It presupposes that we're going to tell our teenagers what they don't want to hear, and they're not going to necessarily like us.
A couple things that come to mind hearing what you have to say. I could imagine a parent saying, well, some of the symptoms of perhaps an opioid addiction are kind of how my teenager has always been for this past 6 months. But Mina, how do I recognize a difference? And a second thing is, so should a parent, maybe if they're going to be hanging out with one of their friends, call the other parent and say, hey, just want to touch base and
are you there?
Are you there? And,
that's a big one.
Yeah.
It's amazing because as much as we want to trust our children, they lie. And so it's important for us to understand that and not take it personally. They want to avoid conflict. It's part of life. But it's that significant behavior change. It's the significant change in who they're hanging out with. It's looking around your home. Has medication disappeared? Be aware of what's in your home. Be aware of what's going on. Look at your child. Have conversations with them. Oftentimes we're passing each other in the home, going to school, going to work, doing those types of things. Look at them. Has there been significant weight loss? Have their grades dropped? Do they just seem to have that serious personality changed? Perhaps they were very gregarious, very outgoing, and yes, part of that is adolescence, but have they withdrawn from everybody? Are they spending a lot of time in their room and not coming out, not wanting to come out?
Not engaging.
Not engaging.
And if a parent thinks about this, I think sometimes what happens, you kind of almost don't want to believe what you're seeing,
Yes.
and you're not sure, am I jumping the gun by trying to do something about this, or is this really going on? So how does a parent maybe start to recognize some of these symptoms and take it to the next step of maybe getting an opinion or intervention?
I think first thing is to have that conversation and have that interaction with your child or your teenager. Denial is a very powerful emotion that we have. We don't want to look at what can be very, very obvious. So it comes on to us to realize that, again, as a parent, I have to address some things that I may not want to address.
It's uncomfortable.
It's uncomfortable. But when we look at it, those individuals, it's far more uncomfortable to go to a funeral. Mm-hmm. And I think that's what we have to look at. We have to look at, if we do not speak about the elephant in the room, it will kill us. And that's what's happening. And parents will say to me, I saw things and I didn't do anything about it because I didn't want my child to be angry at me. They're going to be angry at you. You're addressing their behavior. And I hope that I address a behavior and I'm wrong. Mm-hmm. I look forward to being wrong, but I'd rather be wrong than I said.
I think sometimes, parents, understandably want to be loving and have all positive interactions and sort of be their child's friend in a way. But there's really one opportunity to be a parent when they're in your household and while they're growing up. And I think that's really what that child needs. They need a director and somebody to show them right from wrong and to call them when there's something to be called upon.
Absolutely.
And that's how we all grow up.
Well, and I think
and
part of it too is that we have to address our own behaviors as parents. Mm-hmm. We have to look at our own use, our own what we do. How do we deal with life? Do we deal with life that whenever we have an ache or pain, we're popping a pill, we're taking something? Are we looking at alternative aspects and treatments? Are we practicing what we're preaching? Because if you want to break a relationship with someone faster than anything, it's the hypocrisy of do as I say, not as I do.
And you bring another great issue. Children, I think, more than anything else, will follow the example they see, as opposed to what they're being told.
Absolutely.
I want to ask you, how is addiction treated?
Well, in many cases, if someone is physically dependent, they're going to need to go through what we call detoxification, and that needs to be medically managed. People don't need to suffer, and that's one of the things that I really want to bring up. We are not going to legislate ourselves out of this situation. We are not going to legalize our way out of this situation. This is not about making people a criminal because they've become addicted to a medication and now it's moved into a dependency. Yes, do they engage in oftentimes illegal activity in order to obtain? Yes, that needs to be addressed, but we need to look at that the person is in pain. I read a really interesting article, it was in Psychology Today last month, that loneliness fires off the same receptors in the brain as pain. So when we look at why individuals are taking these medications, 9 times out of 10, they're not taking them because they're in physical pain. They're taking them because they are in emotional pain. And I'm not talking about mental illness. I am talking about a disconnect that we have within our society right now that is causing people to feel isolated, lonely, just completely, like I said, totally disconnected from other people.
Judy, your point is very well taken. I think it's particularly difficult for school-age children. It's one of the most difficult times to go through in life. Who are we? How do I fit in? What if I'm shy or I'm not the football star or the prom queen, or I'm not the brilliant person in the room. What if somebody just doesn't naturally tend to have a lot of friends for whatever reason? That's difficult. It's hard to be isolated.
Absolutely. Part of our basic needs, as Maslow's hierarchy of needs, first need is for food, shelter, and water. Our next need is for relationship. We are biologically programmed to be in connection with other people. I take your point. Growing up is very difficult. We all feel uncomfortable. We all have what I call limiting beliefs and a critical inner voice. Whether that critical inner voice starts with what our parents say to us, whether it starts with the bombardment within society, whether it starts in social media, which in a day and age where we have more connections than I've ever seen, we are more disconnected than we've ever been.
We're not talking to each other as much. We're not touching, the human contact. It's more isolated. We only have a couple of minutes, and I don't want to leave this out. This is so important. How would somebody contact you or be involved in the Eastwood Clinic if they feel, gosh, I need to be aware of this. I need to get intervention.
We are all over the Detroit metropolitan area, so as easy as Googling us, or in the old days, looking in a phone book, calling, we are oftentimes connected to one of the larger hospitals. So here in Detroit, at Maross, we have Eastwood Clinic, St. Clair Shores, like I said, Shelby Township. Just Google us. We're online. You can get a hold of us. If we're not able to meet your needs, which isn't going to happen, there are many, many other places that
somebody
could go.
And
start a conversation.
Don't be afraid to seek help. And if what you perceive isn't what's happening, great. But it's the perfect time, to intervene.
And to have these conversations.
And to have these conversations. Talking is so important. So we're going to wind down.
Okay.
Judy, it's such a pleasure having you. You're perfect. And thank you for all the information. Judy Malinowski.
Thank you for inviting me.
And thank you to our viewers as well. As always, we appreciate the time you take out of your day to tune into our show, In a Heartbeat. I'm Dr. David Balle. Thank you. Have a great day and take good care of yourselves and those around you. See you next time.